All right, what's going on, guys? How you doing? Mike the Caveman Q here again, Paleo Problem Island, MikeTheCaveman.com. Got another edition of Monday Nights with Mike, live stream Q&A. In fact, it's our first of 2018. So, oh shit, let's mute that. Let's try to make sure this thing is actually going working out. It's my first time trying Facebook Live with the OBS. I've been on YouTube for a while now, so here we go. But yeah. So you know the deal. Questions, comments, keep them rolling. Uh, what I've been doing over on YouTube recently is I've been going through different studies and stuff while waiting for questions to come in. And then as questions come in, we can either save that for a little bit later or we can move forward and bring it back. So, yeah, let's get started with this. The paper we're going to be looking at right now that I picked up for today is a paper called The Efficacy of the Autoimmune Protocol for Inflammatory Bowel Disease. And what it is so the autoimmune protocol has been around for a while. Autoimmune paleo was part of where we were. It's kind of like a stricter version of it for a lot of different autoimmune conditions. And the way it worked is you take your normal paleo, no grains, legumes, no dairy. You take that out, and then from there you also will take out nuts and seeds, coffee, alcohol. You're gonna take out nightshades, which are your red peppers, bell peppers, oh, that's the same thing. Bell peppers, tomatoes, eggplant, things like that, potatoes. And while it's been used both clinically and anecdotally, empirically for a long time, only recently did it start to actually get looked into by the literature. And so one of the first papers that actually came out a couple months ago. And here we go. We'll start with this one. Excuse me. So, data suggests that dietary modification can improve responses in inflammatory bowel disease. The goal of the study was to determine the efficacy of an autoimmune protocol in diet in patients with Crohn's disease and ulcerative colitis. Now, we've done a video before specifically on what we can do about inflammatory bowel disease, and that's what we're looking at here. But we're going to look at specifically the autoimmune protocol in depth and what the research actually says. Now, we enrolled adults with active IBD and which are, then it gives the description of what they are and how they've been diagnosed. For the autoimmune protocol, patients underwent a 6-week elimination followed by a 5-week maintenance program. Clinical indices, laboratories, and biomarkers were assessed at baseline and at the 6 and 11-week marks. Endoscopy was performed at study completion. The final cohort included 15 patients with with inflammatory bowel syndrome. Not the same thing. I have made that distinction before. IBS, irritable bowel syndrome. IBD, inflammatory bowel disease. There is a difference. With mean disease duration, 19 years, with a standard deviation of 14.6, and an active biological use in 47% of the patients. Nutrient repletion was initiated for deficiencies in vitamin D and in iron in 3 and 6 patients, respectively. From weeks 0 to 6 and 11, mean partial Mayo score significantly improved 5.8 to 1.2 and 1 for ulcerative colitis, and mean Harvey-Bradshaw index significantly improved from 7 to 3.6 and 3.4 for Crohn's disease. C-reactive protein, which is an inflammatory marker, did not significantly change during the study. Mean fecal calprotectin, so mean fecal calprotectin, improved from 471 at week 11, and among those with follow-up endoscopy at 11 weeks, improvements were noted in a simple endoscopic score for Crohn's disease and a Rückert score, it's kind of Dutch name, Rückert score, and Mayo endoscopy subscore. Discussion, the basic conclusion here, dietary elimination can improve symptoms and endoscopic inflammation in patients with IBD. Randomized trials are warranted. All right, so building on that for now, let's actually break down this actual paper here. So, inflammatory bowel diseases, which include both Crohn's disease and ulcerative colitis, are complex gastrointestinal disorders that arise in genetically susceptible hosts due to factors involving T-cell dysregulation, gut dysbiosis, and environmental exposures and factors. So, talked about all of those independently before, but essentially, what we're looking at right here, by looking at all of these details, yeah. We're looking, sorry, just checking here to see what's going on here with the live. My bad. So we talked all those independently before, but basically, We're looking at T cell dysregulation, that's your immune system, gut dysbiosis, your microbiome, right? We talk about that all the time. Environmental exposures and dietary factors. So all of those factor in together. And basically, we talked about before that you have your genetic template. That's your basically your blueprint to how your body should work. And then from there, all the other factors decide. The architects, the specialists, everybody else, the plumber, the electrician, make little changes that can tweak up how the blueprint of your house actually ends up looking in real life, how your house looks like after moving around that blueprint. So all of those, your immune system function, your gut, the microflora that inhabit your gut, your environmental exposures, so things that you happen to come across, and what you eat can all change that. And if you are susceptible, if you won the genetic lotto, then yeah, that's what your blueprint says. You could be more susceptible to ulcerative colitis and or Crohn's. It could develop. But more than 200 genes have been identified that may increase the risk of IBD, but account for only a modest proportion of disease variants, 13% for Crohn's disease and 7% for ulcerative colitis. Therefore, inflammatory bowel disease is considered a complex polygenic disease that is strongly influenced by environmental factors. Among these, diet and the gut microbiome, two related environmental factors, are hypothesized to be particularly important risk factors and can be modified to influence disease risk and course. And again, when we talk about IBD in the video, talked about how potentially the hygiene hypothesis and how your gut may actually be attacking itself in the absence of parasitic helminths. It's a possibility that your body's starting to attack your own bacteria, and could be what we're looking at in the case of Crohn's. But more on that in a little bit. So, despite diet being implicated in the pathogenesis of IBD, we have limited data to guide the use of nutritional therapy as either primary or adjunctive treatment for these conditions. Conventional medical therapy for IBD focuses on suppression of the immune system by targeting a variety of pathways, yet response rates continue to remain suboptimal. But yeah, response rates brain. So, what we're saying there. So we've talked about before about immune dysregulation in general. Autoimmune falls under the category of an overreactive response to something inside your body. Now, why is that? Well, what's the natural course in terms of a conventional model? Well, if you're overreacting, it means we got to bring you back down. So we have to administer immunosuppressants. The problem with that is that a lot of times that can go too far, making you more susceptible to underreactions to internal and or external stimuli. So that could be either infections in the case of an external stimuli or cancer in the case of an internal. So immunosuppressants, not necessarily always the best thing. So we need another way. So therefore, there is an important need to study dietary factors that may not only help improve response to conventional treatment, but also be potentially used as a primary therapy or maintenance therapy for patients with IBD. A Western diet high in refined carbohydrates, omega-6 fatty acids, saturated fat, low in fiber, vitamins, and generally nutrient-dense foods are associated with an increased risk of IBD. Recent, albeit limited, data suggests that a semi-vegetarian allowing milk, eggs, fish once per week, and other meat once every 2 weeks, specific carbohydrate diet, with the removal of grains, most dairy products, and sweeteners except for honey, or an anti-inflammatory diet, which is a modified carbohydrate and fatty acid intake, and increased prebiotic-probiotic ingestion, can be associated with improved rates of achieving and maintaining clinical response. So in these cases, we're looking at the removal of grains. We're looking at the removal of dairy in the case of the specific carbohydrate diet, as well as all sweeteners except for honey. And the other one is the modified carbohydrate, basically removing the other one. So summarize, 3 different diets that have shown some kind of benefit in Crohn's and ulcerative colitis are semi-vegetarian, specific carbohydrate, and the anti-inflammatory diet. So what we're looking here is the autoimmune protocol, or the extension, which is a diet extension of the Paleolithic diet, and incorporates some of the dietary changes previously studied in IBD, including the avoidance of gluten and refined sugar. The IP diet focuses on initial elimination phase of food groups including grains, legumes, nightshades, dairy, eggs, coffee, alcohol, nuts and seeds, refined processed sugars, oils, and food additives. The rationale is to avoid foods, additives, or medications such as non-steroidal anti-inflammatory drugs that can trigger intestinal inflammation dysbiosis, and or food intolerance. It also emphasizes consumption of and preparation of fresh, nutrient-dense foods, bone broth, and fermented foods, while addressing factors that are known to associate with disability due to IBD, such as sleep and sleep hygiene, stress management, forming a support system, and physical activity. And if we look at this here, these are all things that I say all the time, right? All super important things. The elimination phase is followed by a maintenance phase, the duration of which can vary by individual until they achieve a measurable improvement in their symptoms and overall well-being. Stage reintroduction of food groups is then initiated gradually as patients identify unique foods or food groups that may contribute to symptoms while liberalizing their diet. So we talked about that before too. Do you need to be on a elimination diet for your whole life? Probably not. What you can do is eliminate for a period of time, at which point you can reintroduce, see how you feel, and figure out which ones you need to keep out. And if you improve it well enough, maybe sometimes there's enough repair, you might be able to sneak in a little bit here and there. But based on increasing evidence suggesting an impact of diet on clinical disease activity and IBD in our clinical experience with patients pursuing the AIP protocol for their symptomatic IBD, we performed a prospective study to evaluate the potential efficacy of the autoimmune protocol in patients with active Crohn's disease and ulcerative colitis. So that right there is our intro. We are looking at how it works. Methods, how they do this? Well, they conducted a single-center, open-labeled, uncontrolled study designed to determine potential efficacy of the AIP diet in patients with active CD and ulcerative colitis, what you see. So what that means, one place, open-labeled, uncontrolled, meaning everybody got the AIP protocol that is in this. So it usually is what's called the intention to treat. So everybody got the same protocol. There is no blinding because that's kind of the problem with food research or clinical trials in food and nutrition. It's pretty tough to blind the food unless we're talking about shakes, in which case, that might be a little bit easier. But in this case, because, everybody knew what they were eating, it's obviously it's obviously open labeled, so you know what you're getting. And because they wanted to really determine how this was going to work, they didn't put it next to a control group. Now, the nice part is that there have been a number of studies that have been done previously on different diets, those that can actually act as a comparison group, but back to that later. Eligible patients were enrolled through the Scripps Clinic Medical Group Division of the Gastroenterology at La Jolla. La Jolla, I've heard that scene like in movies and stuff. La Jolla, I don't know. California. Study participants provided written informed consent under protocol approved by the Institutional Review Board of Scripps. Eligible patients, INCPA, because it's usually international, so the IRB, so it's usually International Review Boards, but whatever. It's Institutional Review Board of Scripps. Eligible patients included adults ages 18 and over with either symptomatic CD, defined whatever, or ulcerative colitis. And objective evidence of active disease was also required for study inclusion, including either an endoscopy by either colonoscopy or flexible sigmoidoscopy, or imaging, video capsule endoscopy or enterography within 7 months of enrollment, or elevated calprotectin within 1 month of enrollment. Additional inclusion criteria included an established. It's actually pretty funny. I missed that part before. Additional inclusion criteria included an established Facebook account and being comfortable with the use of the internet-based surveys and email. Exclusion criteria included being pregnant or breastfeeding women, patients with known celiac disease or history of positive TTG antibody, evidence of untreated disease infection such as Clostridium difficile, presence of stroma or J-pouch, bowel surgery within 12 weeks before enrollment or deemed likely during study period, use of tube or enteral feeding, elemental diet, or parental alimentation within 4 weeks of study initiation. Dosage of medications being used to treat IBD before enrollment was advised to remain stable during the study period with the exception of tapering of corticosteroids. Now, as we talked about before, corticosteroids are immunosuppressants. They are anti-inflammatory as well, but you don't really want to be on it for that long of a time. So that is one of the big problems with, conventional treatment for Crohn's disease. You kind of have to be on them for quite a bit of time. So here by tapering them down, you're able to basically try and regulate that out. But as a pilot study examining efficacy of the AIP diet in active IBD, no minimum duration of medication use was required before study enrollment. So, what was dietary intervention? The AIP dietary intervention, because I'm sure a lot of you are thinking, like, what the hell did they eat? We removed all those other things. What the hell is left? But here we go. So, the AIP dietary intervention consisted of a 6-week elimination phase. 6-week elimination phase. Stage elimination of grains, legumes, nightshades, dairy, eggs, coffee, alcohol, nuts and seeds, refined processed sugars, oils, and food additives. This was followed by a 5-week maintenance phase. I can't say the word phase apparently. Anyway, this was followed by a 5-week maintenance phase during which no food group reintroduction was allowed. Using the SAD to AIP in 6 diet transition program, all participants began the study on September 5th, 2016 and completed the study on November 18th, 2016. As an initial pilot study of AIP for active IBD, we did not formally examine reintroduction of food groups after the maintenance phase. The study incorporated a certified health coach who conducted the dietary intervention and a registered dietitian to provide one-on-one feedback to participants. The program also counseled participants on forming a support system, grocery shopping and food preparation, sleep and sleep hygiene, education regarding nutrient density in fermented foods, stress management, incorporation of bone broth and physical activity, avoidance of non-steroidal anti-inflammatory drugs, and that. Health and group-based coaching and dietary counseling were provided through individual email and a private Facebook group accessible by invited members only. Because participants began the study at the same time, they could communicate with one another through the Facebook group, but study investigators and staff were not part of this group. During the study, participants were asked to record dietary intake, which was communicated through email and reviewed by the health coach and dietitian. Participants also completed quality of life assessment during the study using the short inflammatory bowel questionnaire. Is the questionnaire short, or is the bowel of it, or is the condition short? Is it an acute condition? Did it last a short amount of time? Is it a short bowel? Do they have sorry, it's terrible humor in my own head. Never mind. Before the study, participants received 2 books on the AIP diet and recipes: the Paleo Approach, Reverse Autoimmune Disease and Heal Your Body. Reverse Autoimmune Disease and Heal Your Body by Ballantyne, published in 2014, as well as the Autoimmune Paleo Cookbook, an allergen-free approach to managing chronic illness by Trescott, also published in 2014. Office visits at baseline before study start and end of study, and laboratories baseline week 6 and week 11 were conducted at Scripps Clinic. Endoscopy, radiology, and or biomarker assessment were performed at baseline and at study completion to assess mucosal healing. At the end of the study, participants were provided guidance on any continuation of maintenance phase and stage reintroduction of food groups. The goal of the study was to evaluate the potential efficacy of the autoimmune protocol diet for patients with active Crohn's disease and ulcerative colitis. The primary outcome was to examine a portion of patients achieving clinical remission for CD and UC at study completion of 11 weeks. Clinical remission was defined as an HBI of less than 5 for Crohn's disease and a partial Mayer score sum of individual scores for stool frequency, rectal bleeding, and physical physician global assessment of less than 2 for ulcerative colitis. Excuse me. Secondary measures included achievement of clinical outcome measures at week 6, end of elimination phase, changes in biomarkers and endoscopic disease activity from baseline to week 6 and 11, changes in steroid use among those with active use at baseline. That's, of course, corticosteroids and not necessarily anabolic. I'm not sure they actually tested for that, but John Jones might have been okay on this test. But examination of any adverse events during the follow-up period. Analyses of clinical outcomes were performed for those patients with follow-up data at both weeks 6 and 11, whereas analyses of biomarkers such as C-reactive protein or fecal calprotectin were performed for those with follow-up data at week 6 and or 11. Only one patient with Crohn's disease was lost to follow-up during the study before assessments were made at week 6 or 11. Secondary analyses of clinical outcomes carrying forward this patient's baseline data were conducted to minimize bias due to the loss of follow-up. And this was accounted for in the results. they used a paired t-test to basically run the differences, examine the differences between the data, and a Fisher's exact test was used to determine whether IBD type was associated with primary outcome. So they enrolled 18 patients. 3 patients withdrew before study start because of inability to commit to dietary change. And as somebody who works in this community, that's definitely a major problem. The final cohort included 9 participants with Crohn's disease and 6 with ulcerative colitis, so a total of 15. Among the 9 with Crohn's disease, 5 had, or 56%, had post-operative reoccurrence of Crohn's disease, 3 ileal and 2 ileocolonic. Before study start, 8 of the 9 participants with Crohn's disease had active disease on endoscopic evaluation with visible erosions or ulcers in the diseased regions, 5 of whom had elevated fecal calprotectin. 1 participant with Crohn's disease enrolled in the setting of only an elevated fecal calprotectin with colonoscopy within 1 month of study showing no active erosion or ulceration. At baseline, C-reactive protein was elevated in 33% of participants, or 5 of 15, with a mean C-reactive protein of 7.3, and mean fecal calprotectin was 392 micrograms per gram. All 6 participants with ulcerative colitis had active disease on baseline endoscopy with Mayo endoscopy scores, MESS, of 1, 2, and 3. 5 of the 6 patients with ulcerative colitis had elevated fecal calprotectin at baseline. So basically, again, to break that down, fecal calprotectin is a biomarker letting you know what is generally indicative of an inflammatory response in the intestines, whereas C-reactive protein is a systemic inflammatory marker that's used for practically anything. If we see elevations in that, it's usually not a good thing. But moving forward, mean IBD duration was 19 years, standard deviation of 14.6, and active biological use in 7 participants. Types of therapy among those with active biological use included infliximab monotherapy, adalimumab monotherapy, vedolizumab monotherapy, and zidolizumab combination therapy with biopurine or methotrexate. Mean duration of biological use before studies was 1.8 years. So basically, they were using that for an average of basically about 2 years. 2 patients started infliximab and or zidolizumab. Pharmaceuticals are not my strength. Yeah. Mean duration of biological use before the study. Sorry, looked away for a second, got distracted. Squirrel. Mean duration of biological use before study was, I just said that part already. One patient with severe ulcerative colitis initiated infliximab monotherapy 20 days before the start of the study, and 1 patient with ileocolonic Crohn's disease with post-operative recurrence and anastomotic I don't know that word. Anastomotic stricture. The hell does that mean? You got me on that one. Let's find out. Anastomotic stricture. That looks lovely. Colorectal or colocolic anastomotic stricture is a common complication after colorectal surgery. Traditionally, endoscopic balloon dilation technique. Let's see. Ugh, looks like a hole. So what is anastomotic? That looks lovely though. So, anastomoses is connection or opening between 2 things, especially cavities or passages. Aha. Surgical. So, other examples include Roux-en-Y anastomus. Basically, when a segment of the intestine is resected and 2 remaining ends are sewn or stapled together. So in this case, it's pathological. Aha. So usually referred to as fistula. Okay, so I know what a fistula is, but got it. That makes sense now. It's a different way of calling it that. So yeah, basically one section One section goes and while so let's say it was a urinary and a bladder and the colon. Basically, there could be a growth where your colon then attaches to your bladder. Not a good thing. So there's an anastomotic stricture on the upper oral methotrexate. So that person was put on oral methotrexate, initiated zitalizumab therapy in addition to methotrexate, 75 days before the study start. Excluding these two patients, mean duration of biological use before the start of the study was 2.5 years. So basically, those two started within a 1 to 3 month frame. Everybody else had been on it for almost 3 years. Nutrient depletion was initiated for nutrient deficiencies in vitamin D and iron. So, if you're not familiar, common issues in IBD, particularly in those with Crohn's and ulcerative colitis, which is the two main parts of IBD. So I don't know why it's particularly whatever. Anyway, a common problem is malnutrition. So the damage done to the gastrointestinal tract makes it such that you don't absorb nutrients very well. And so there are often a lot of different micronutrient deficiencies. In this case, they actually went and provided supplemental vitamin D and iron in 3 and 6, respectively, just because the people that were that low. But moving forward, right here we have characteristics of study participants talking about their age, etc., etc. Outcome measures. Clinical remission was achieved at week 6 by 11 of 15 study participants, 6 with Crohn's disease and 5 with ulcerative colitis. And all 11 maintained clinical remission during the maintenance phase of the study, so the following 5 weeks after that, so a total of 11 weeks. Mean total SIBDQ score significantly improved from 46.5 at baseline to 53.3 at week 6 and 60.5 at week 11. One patient with post-operative recurrence of ileal Crohn's disease without stricture continued to have mild, moderately active Crohn's disease throughout the study, although noted resolution of joint pains, which, again, common thing that we could see during a autoimmune protocol. You see reductions in inflammation elsewhere. The other main benefit being probably the person was put on a buttload of bone broth because that was a key point that was mentioned earlier. So the bone broth in and of itself could do it, but just the general anti-inflammatory properties of some of the removals and additions to the diet, good things. One patient with left-sided ulcerative colitis continued to have mildly active symptoms. Partial Mayo score remained at nothing said John Mayer score. Partial Mayo score remained at 5. Among participants with ulcerative colitis with complete follow-up data at weeks 6 and 11 from week 0 to 6, mean partial Mayo score improved from 5.8 to 1.2. And this was sustained through week 11. Among participants with Crohn's disease with complete follow-up data, the mean HBI score improved. The numbers part is not necessarily as important right now. But achievement of clinical remission did not differ significantly between Crohn's disease and ulcerative colitis. Secondary analyses conducted, including the one participant with CD or Crohn's disease who was lost to follow-up and did not alter the primary results. So the mean HBI score improved from 7 to 4 at week 6, and at week 11 improved to 4.1. All right. Again, basically here, no statistically significant differences were observed for hemoglobin, hematocrit, albumin, transaminases, trying to say that too fast, transaminases, bilirubin, creatinine, total cholesterol, high density lipoprotein, triglycerides, low density lipoprotein from weeks 1 and 0 or 11. There was also no significant change in patient weight from baseline to study completion. Now, did it mention caloric intake? It did not. So that's the baseline characteristics. So yeah, there's no mention of whether it's isocaloric or whether or not they actually changed the intake, but whatever. That likely has a bigger play in hand than otherwise. All right. So here we have another table regarding the effect of the autoimmune protocol diet on clinical inflammatory bowel disease activity. So we have symptoms at week 0, so baseline, at week 6, and then the p-value. Then we have week 11, again, the p-value to determine whether or not these are significant. So looking here, we have HBI mean, abdominal pain, bowel movement and frequency. We have general well-being mean, complications, the ulcerative colitis here. We have partial Mayo score. We have the stool frequency, rectal bleeding, physician's global assessment. So basically what the doctor was saying was going on. So basically, we see here the HBI, we see a drop of about half after that. And then at week 11, it was maintained. So the maintenance phase, properly maintained. In the case of abdominal pain, we saw a mild drop, but then it went and normalized back to the same level. In terms of bowel movement frequency, it dropped, so it was less often. And oftentimes, when we're looking at inflammatory bowel disease, unfortunately, the bowel movements are too frequent. Diarrhea is a common symptom. But if we look here, it dropped from 3.4 to 2.4 on average, and then ended up remaining at 2.4. So it had less bowel movements overall. The general well-being, it went from 1.6 to 0.3. I don't know how that was measured. Because I feel like if it drops, that would be like a not improvement. Hold on. I skipped. I was going through the results. Ah, you know what? Somebody mentioned calories, but this won't let me search. Huh. I have an idea. I have an idea. First of all, let's see. Four. Hmm. That's weird. Is the table not available here? Probably not. That's why. That makes more sense now. They didn't mention how well-being was measured. Huh. Interesting. Well, having established that, or not, theoretically their well-being improved, but maybe it didn't. Tough to say. Whether that number dropping is a good thing. Whatever. Complications. Complications definitely, though, dropped from 1.1 to 0.1, and then it rose slightly to 0.4. In terms of the partial Mayo score in the ulcerative colitis patients, went from 5.8 to 1.2. Stool frequency went from 2 to 0.2 and remained as such at the 11th week mark. Rectal bleeding, because you know how lovely that is, went from 1.8 to 0.5 and remained. It actually dropped even further to 0.3. So big changes there. And the physician's global assessment went from 2.0 to 0.5. More benefits. So from there, how does it look in terms of their effect of diet on fecal and serum inflammatory bowel disease biomarkers? So we're looking at fecal calprotectin baseline of greater than 50 nanograms per gram. We have their C-reactive protein as well as their albumin, which is a protein marker that's pretty important. So we see that a sample of 8 of them so we had 267 score at week 0. It dropped all the way to 157. The baseline fecal calprotectin above 50 was 412 for 5 of them and dropped to 196. The C-reactive protein went from 8.3 to 7, and albumin remained the same at 3.9. Then week 0 versus week 11 results, the fecal calprotectin went from 471 to 112. We have here the baseline went from 701 to 139. The C-reactive protein went from 3.9 to 3.4, and then the albumin, basically again, about the same, 4.1 to 3.9. So, although we advise no medication change before the study start, one participant discontinued oral mesalamine therapy, but achieved clinical remission by week 6. Another participant discontinued oral mesalamine, but continued mesalamine suppository, and also noted a decrease in partial Mayo score from 5 to 0 by week 6. 2 of the 3 participants were able to discontinue steroid therapy in both partial Mayo score clinic decreased to 0 by week 6, and one patient on systemic steroids was lost to follow-up because of insurance change. One participant with post-operative recurrence of ileal-Crohn's disease with known ileocolonic anastomotic stricture required hospitalization for partial small bowel obstruction approximately 3 weeks after study start. This was attributed to a significant increase in raw vegetables, salad, and meat consumption. This participant did not communicate with health coach or dietitian regarding dietary changes in the setting of known stricture. Participant's symptoms resolved overnight with the use of intravenous steroids, and patient was discharged on rapid steroid taper. This patient was subsequently lost to follow-up, and we were unable to make assessments at week 6 or 11. Another patient with ileal-Crohn's disease with ileocecal valve stricture, ileocecal valve stricture, withdrew before the end of elimination phase because of worsening symptoms. Week 6 assessment was not made. Notably, this participant experienced increase in biomarkers from week 0 to 6, with fecal calprotectin increasing from 449 to 758 and C-reactive protein increased from 36 to 41. Although there were no significant differences in lipid subtypes between weeks 0 and 6 or weeks 0 and 11, some participants did experience small rise in triglycerides or LDL that prompted dietary modification by the registered dietitian and health coach. Now, again, it's kind of tough to say exactly what was in these diets. Now, having said that, you can go look at those books and make sure that, everything's solid. But what's even more important here is the fact that they're still in a free living condition. Yes, they were advised on what to do, but part of the problem with non-metabolic ward studies is you don't necessarily know if you can trust the person to actually eat that. Now, the one person with the stricture, his problem or her problem, we don't know for sure. I don't know for sure. I wasn't talking to the person. The known stricture there. Yeah, the fact that they had a section of their colon that was connected to another part. So ileum, so basically their ileum was connected to their colon. That's not good. So because that's going on, kind of important to figure out or know that ahead of time and make necessary changes as needed. Anyway, let's just get to the discussion. So increasing evidence suggests that dietary modification can modulate inflammation and improve clinical responses in IBD. Our prospective observational study indicate that an AIP diet involving an elimination phase followed by maintenance phase demonstrates preliminary efficacy in patients with active IBD. We also identify improvements in fecal calprotectin along with endoscopic improvements in the mucosal appearance in most patients undergoing follow-up endoscopy. Our results support the use of dietary modification as an adjunct to IBD therapy. Clinical remission was achieved by week 6 by 11 of 15 or 73% of the study participants, and all 11 maintained clinical remission during the maintenance phase of the study. We did not hypothesize a priori that clinical remission would be achieved so early, week 6. So basically, a priori means that that's the foundational principle. In their minds, they thought, okay, these people with Crohn's, it took them a little longer than 6 weeks to get to this point, that they're probably not going to be in clinical remission within 6 weeks. However, the fact of the matter is all 11 of those 15, so 73% of the participants, achieved clinical remission within that period. And they maintained it. So 6 weeks was the elimination phase. They went to a maintenance phase for the remaining 5 weeks and still remained at clinical remission. So, pretty impressive. Indeed, this proportion of participants with active IBD achieving clinical remission by 6 weeks rivals that of most drug therapies for IBD. This bears repeating. Again, indeed, this proportion of patients with active IBD achieving clinical remission by 6 weeks rivals that of most drug therapies for IBD. So the autoimmune protocol diet is basically as effective as most drug therapies for IBD. That's huge. Now, again, sample size isn't ginormous, but bear with it. This is a pilot study. But importantly, our dietary study was performed as an adjunct to medical therapy, and almost 50% of the patients in our study were on biological therapy. Therefore, our results suggest that dietary modification can be useful as an adjunct to conventional IBD therapy, even among those with moderate to severe disease. Importantly, the two participants with Crohn's disease with ileal strictures, native or anastomotic, developed either worsening disease activity or partial small bowel obstruction. Therefore, although dietary elimination can be helpful, consideration should be given to anatomical variation and requires counseling and close follow-up. So, key here, if your anatomy is not the way it's supposed to be, there are changes through one means or another, whether it be through birth or through surgery. Let the person who's helping you out with your diet know that so they can make the appropriate changes. Otherwise, you could have some major problems. Cool? Awesome. So, the premise of the autoimmune protocol diet as a whole involves a staged elimination of food groups that may be associated with immune stimulation and intolerance, maintenance of the eliminated foods, followed by staged reintroduction of certain foods or food groups over time. The purpose of the study was to examine the potential efficacy of the autoimmune protocol diet for IBD, and as such, we focused on the elimination phase and a minimum 1 month maintenance phase. Our study design was adapted from our Health Coaches online program, which focuses on 6-week elimination phase. The maintenance phase in practice can occur for participants anywhere from 30 to 90 days, although some continue it even longer, before starting to reintroduce food groups. The protocol emphasizes healthy food behaviors aimed at increasing nutrients density out of the diet, incorporating fresh fruits and vegetables, healthy sources of fats, lean proteins, fermented foods, and, for our study, modifying intake according to IBD phenotype, such as strictures. The protocol also recommends avoiding nonsteroidal anti-inflammatory drugs and low nutrient density processed foods, which may also contain emulsifiers or additives that can perpetuate inflammation while improving the lifestyle behavioral factors such as sleep hygiene, stress management, and physical activity. Given the association of stress with IBD flare and low physical activity or nighttime sleep with the risk of IBD, addressing these aspects seemed logical, although they were not formally studied. So yes, it's a relatively well-known thing that in the case of Crohn's, stress events, poor sleep, and sedentary lifestyle will all lead to increased preponderance of the disorder. So making sure to look at those and taking a more whole I hate the word holistic, so I'm not using holistic, but taking a systematic approach to the whole body. Probably easier to say holistic, but whatever. By doing that as a whole, yeah, you're going to see better results. However, in the case of this, while they were advised to do those things, they were not studied in isolation. But as such, it is not possible to determine how much the apparent effectiveness of the dietary lifestyle intervention was due to the non-dietary aspects. An important goal of therapies for IBD is to reduce inflammation. Clearly, the name of the disorder is inflammatory bowel disease. It's right in the name. So, reducing inflammation obviously is a key thing. Although not statistically significant, we did note the decreases in fecal calprotectin, particularly in patients with ulcerative colitis. Furthermore, rectal bleeding was significantly reduced by week 6 and 11 among patients with ulcerative colitis. The baseline C-reactive protein was also within normal limits in most, 66% of the participants, and no statistically significant differences were noted between baseline and follow-up C-reactive protein measurements. Among those among those with endoscopic improvements in mucosal inflammation, we noted decreases in fecal calprotectin, consistent with studies demonstrating better correlation of mucosal findings with fecal calprotectin than clinical symptoms or indices. So basically, the subjective markers, do you feel better? How much pain do you have? So the actual improvements, the actual degree of inflammation in the mucosal lining of their intestines was correlated. It was linked to the decreases in the fecal calprotectin. So those that actually saw greater decreases in the fecal calprotectin, the biomarker that helps to indicate it, they saw greater increases in the regrowth or reductions in inflammation of mucosal lining. So even if they didn't necessarily feel better yet, their intestinal physiology, anatomy and physiology were improving. Cool? All right. The strengths of our study include a prospective design and focus on patients with not only clinically active IBD, but also objective evidence of inflammation. Nutrient repletion was also initiated for patients with baseline deficiencies in vitamin D or iron, which would have helped to reduce confounding influences of micronutrient depletion on disease activity, but whose repletion may have also impacted improvements in general well-being noted during the study. Through our through our I wasn't sure if it said through or though. Anyway, through our novel study design incorporating social media, study participants also had the unique ability to communicate with one another and our health coach and dietitian through a secret and private Facebook group. Post-study follow-up visits suggest that online engagement, sharing of similar experiences and recipes, and convenience of communicating with health professionals directly were viewed favorably by participants. Limitations of the study include small size, lack of randomized trial design involving a control group, lack of blinding, and potential for selection bias among those enrolling in the study. Now, if you're actually reaching out, you're probably going to want to change your life. You're going to be more likely to actually make those changes. Some people, were eliminated. So I think you said there was 18 that went in originally. 3 were kicked out before they even started due to inability to be compliant. So yeah, that's a common problem. Put together a great protocol. People aren't going to listen to it. How great is it? All right. Limitations of the study include small size, lack. I said all of that before, but oh yeah. So the reason why I brought that up, selection bias. So you could potentially be selecting for people that are more motivated to actually make changes. So that in and of itself could be a problem. We included one patient with active Crohn's disease by HBI and fecal calprotectin with no objective evidence of active inflammation by colonoscopy. However, analyses excluding this patient did not alter the primary outcome and indicated that significant improvement in HBI in one patient with CD. 2 patients in our study and one with Crohn's disease and one with ulcerative colitis had initiated biological therapy within 3 months, which could potentially confound the results of our study. Basically, because they had just started their therapy, they started their pharmaceutical treatment, they could potentially have seen better results because they just started their treatment there. So that is a little bit of an issue. But however, secondary analyses excluding these patients again did not alter the primary outcome. Although endoscopic improvement was noted in 6 of the 7 patients completing endoscopic reassessment at the study's completion, it is important to acknowledge that 8 participants did not pursue endoscopic reassessment. And as such, we could not perform statistical analyses to examine the effect of the dietary interventions on mucosal healing. Another limitation includes lack of detailed assessment of the impact of other recommendations such as physical activity, sleep and sleep hygiene, social support, and stress management they had on the clinical scores. So obviously this particular study focused specifically on the dietary intervention. There were other factors that potentially could have helped, but can't really measure them. But in conclusion, our study demonstrates that dietary modification focused on elimination of potentially immunogenic or intolerant food groups has the potential to improve symptoms and endoscopic inflammation in patients with IBD. Dietary change can be an important adjunct to IBD therapy, not only to achieve remission, but also perhaps to improve the durability of response and remission. Perhaps for a subset of patients, dietary and lifestyle modification alone may be sufficient to control underlying luminal inflammation. Patients wishing to incorporate dietary therapy should be counseled on options, assessed for micronutrient deficiencies, and monitored routinely. Integrating and coordinating care with health coaches and registered dietitians can allow for effective education and implementation of dietary modification over time, in accordance with unique patient goals as well. Larger randomized trials are needed to validate these findings and examine long-term course of patients during reintroduction. So there you go. And the authors, they thank Angie Alt, Amy Kubal, Mikey Prescott, etc., etc. of those names there. It's funny. Amy Kuwal is the only one I'm particularly familiar with. Who were the authors on this paper again? Konjeti Kim, Louis Grovin, Chandras Kasan, Mirandi, Diamant, Emily Singh, Oliveira, Wang, Molparia, and Tokamani. Awesome. All right, so yeah, AIP, autoimmune paleo, get it on it if you want to get rid of your inflammatory bowel disease. Possibly. So yeah, um, I was taking a look at it from my phone, and it looked like there was a little bit of stuttering in terms of the camera feed, in terms of it actually pausing every once in a while. I'm gonna have to rewatch parts of that to make sure that wasn't happening. Yeah, what they were about to call it over here. I've been threatening with the release of the fire cream for a while, and should potentially be coming soon. We had some issues with the printer in terms of getting labels done, but they are jarred, they're ready to rock, so hopefully we'll get them out soon, and you'll be able to get it. All right, guys, I will. That was the other thing too. The holidays with Christmas and New Year's and stuff falling on Mondays ended up throwing me off a little bit, but we're gonna get back to the regular weekly installments at the very least, if not the daily installments, like I also keep threatening you with, and who knows? We'll see. We'll get back to it. All right, guys, I will see you next week.